Thanks, Marta. So our next, it's not really a duet. I'm a sort of backup singer. I not really. You'll be glad to know. But the talk is primarily by David Taylor. David is professor of a professor at pharmacy at the Institute of Psychiatry and King's College, and he's also the head of pharmacy. And he was modestly putting his hand on this is the most widely bought book that ever been produced by the Maudsley Hospital. Sorry?
The prize.
Oh, I see. It's also the prize of the poster winner, but
Signed by David.
signed by David. But do we know who the poster winner is yet? Oh, you have to. I see. Till tomorrow. Anyway, this has how many copies has this sold? 300,000. I'd say a little more than anything I've written. Here. But also in the UK, hospital psychiatric services are rated by an audit. And although we are very arrogant at the Maudsley Hospital, we think we're very good at things, we usually get mediocre ratings, except for pharmacy. And we always come top in pharmacy, which is due to the abilities of the clinicians. No, it's due to David Taylor. So if you step out of line, you get some kindly advice that you should be prescribing more sensibly. So I'll hand over to David.
Thank you, Robin. Thank you, Marta and the committee for inviting me to come here again. Just some observations on what Argyris has just said. I hadn't realized that emotions could be deployed, and were only deployed when we could afford to do so. But I'm reminded of a situation my little brother was in a few years ago, where he was driving along a country road and somebody came up behind him, started flashing him, overtook him, abusing him, gesticulating at him, got in front of him, braked sharply. And then they went round the corner and there was a red traffic light, so the car in front had to stop. My brother stopped behind him. My little brother's 6'8", so that's nearly 2 meters tall. He works part-time as a nightclub bouncer. He got out of the car, knocked on the window of the car in front and said, "Is everything okay?" And the driver said, "Yes, fine, thank you, sir, thank you, sir." So his anger had clearly been deployed, and he no longer felt he could afford to deploy it. The other thing I just mentioned was the use of asking somebody to pronounce something in order to identify where they were from, to see if they were an enemy. And I understand, although I did read this in a work of fiction, but I believe it to be true, that one of the ways that the British were taught to detect a fifth columnist or German spy during the war was to get them to repeat the phrase, "Wolverhampton Wanderers won 1-0. Or better still, type it on a piece of paper and get the person to read it out, because it has that shift from the W to the O, all being pronounced the same, all being a W, which is a difficult letter for Germans to pronounce. Anyway, to my knowledge, it was never deployed, because the spies that Germany sent to England were so hopelessly bad that they were all caught within 24 hours, most of them within a couple of hours. And in fact, the only spies that Germany had in England were double agents who were actually working for the British. And one of them famously was Agent Zigzag, who was sent to tell the Germans where the V-1 bombs were landing. And he told them that they were landing too far north. So the Germans adjusted their aim and all the bombs landed on Croydon, which was something of a success. I'm going to talk about long-term treatments of antipsychotics. This is something that's been on my mind since I started working in psychiatry. And soon after I started work at the Maudsley, there was a documentary on the BBC where they looked at psychiatric services, and they showed a patient and his room, which was a terrible mess. There was an interview with a patient, and he made no sense at all. He was responding to voices that nobody else could hear. And then the documentary moves forward to a few weeks later, and there's an interview with the patient with his psychiatrist, and the patient has been reduced to, if reduced is the right word, a dribbling wreck of a man who's virtually unable to speak, has no facial expression. And the reporter kind of, in a sense of slight amazement, I thought, said to the psychiatrist, is this guy like better, in inverted commas? And the psychiatrist said, oh yeah. He's now able to cope with life. His room's going to be tidy. We're going to discharge him next week. And I thought to myself, well, we understand there is a balance to be had between the therapeutic effects of drugs and their adverse effects. But I think we could think a bit harder about that balance. And that's what I'm going to try and talk about. I don't really have any answers, more points for discussion. So should we be more cautious about prescribing long-term antipsychotics? Now, I'm not going to deploy my anger at this stage, but it's not working. Yeah, it's worked, so I can go backwards and forwards. Yes, okay. We start in about 1955 when chlorpromazine was introduced as thorazine to the US market. Our most encouraging results with thorazine have occurred in chronic schizophrenics who were resistant to all psychiatric therapies, including psychotherapy, intensive shock therapy, or did not sustain or maintain improvement after prefrontal lobotomy. After they were placed on the thorazine program, 17 out of 27 of the shock treatment failures improved sufficiently to be discharged home. The revolution here was in the short-term treatment of psychotic conditions. And you can see that revolution in terms of numbers of people requiring a restraint, is this going to work? Which is here. Number of people resident in institutions as they were then, and the rise in the use of tranquilizing drugs, and by that they mean drugs like chlorpromazine. So there's a very distinct, and I suspect not coincidental, association between those things. So in the short term, there's a fairly obvious benefit both in the individual and in populations. At this time, of course, the drugs weren't available for long enough for us to assess their long-term properties. But my understanding of what happened was that the acute effects were assumed to be the same as the long-term effects. That is, that you could treat somebody with schizophrenia with chlorpromazine and then carry on treating them, although I have come across cases or mentions of the idea that you treat people while they're acutely unwell, and then you stop treatment, and then you, if they get ill again, you give the treatment again. Robin and I and a few others wrote this paper a few years ago, challenging the idea that, or the common practice, which is that all people with a diagnosis of schizophrenia require lifelong treatment with antipsychotics. I don't think we were saying that it's definitely true that not everybody requires long-term treatment. It certainly is true that amongst a group of people with first episode schizophrenia, that there will be a proportion of patients who do not require lifelong treatment. But one of the confusing factors, perhaps the most confusing factor, is the fact that nowadays everybody with a diagnosis of schizophrenia gets treated with an antipsychotic, and that treatment itself might alter the way in which the condition pans out during a person's lifetime, particularly through the process of inducing postsynaptic dopamine supersensitivity, which I'll come to later. It's obvious to say that antipsychotics are not innocuous. They're about as far from innocuous as you can get, I suspect. But they have lots of different effects, many of which we're fully aware of, others we're only dimly aware of. Some of them we don't think about often at all, and some, like the idea of neuroleptic-induced deficit syndrome, has kind of been lost from our awareness over the years. This is a paper by our late colleague Malcolm Lader about this well-known syndrome. He's summing it up at this stage. This is in 1993. So he described patients feeling drugged and drowsy, being like a zombie, unable to concentrate, slow and heavy, lack of motivation, and emotionally unresponsive. So we treat people for a serious condition and we give them serious side effects. We also make them unhappy. This is another concept which we don't talk about very often these days, neuroleptic dysphoria. And this paper from 2004 looks at some of the ways in which blocking dopamine function can lead to different effects, including a lowering of mood, often to the extent that people are depressed, a triad of dysphoric mood, tardy thinking, and motor slowing. So these are symptoms that we're asking people to endure for the whole of their lives. We're asking them to endure a lack of motivation because antipsychotics, most of them at least, are associated with amotivation. One of the most cited pieces of work in antipsychotic pharmacology is this one by another colleague, Satish Kapoor, and others, which looked at the degree to which dopamine receptors had to be blocked to induce a therapeutic effect, but also to induce hyperprolactinemia and extrapyramidal side effects. And using haloperidol, he found that above 78% you would see people with extrapyramidal side effects, and above 72% you would see people with hyperprolactinemia, although some had hyperprolactinemia below that. Efficacy was found to be at 65%. One of the interesting things about these findings is that it indicated that you could have a typical drug acting atypically, i.e. without adverse effects related to dopamine blockade, if you just got the dose right. It was just that the difference in that and that and that was a fraction of a milligram, and almost impossible to do in practice. So remember the 65, many of you will be fully aware of it. It's coming up in a minute. Also, we need to bear in mind that these drugs don't only target dopamine receptors, they have lots of other effects on other receptors and systems too, including histamine H1 receptors, which causes sedation and weight gain, and muscarinic receptor blockade, which causes cognitive problems, also associated with a high risk of Alzheimer's. There's also a slightly more nebulous adverse effect of antipsychotics, which we would anticipate, given that these drugs are blocking the reward system, which is a sense of well-being, the self-reported sense of well-being or subjective well-being on neuroleptic scale. This scale can show that people are taking antipsychotics in black or clozapine have greater symptoms on standard antipsychotics than they do on clozapine. And clozapine, of course, is a very weak dopamine blocker, so it may have something to do with the extent to which dopamine receptors are blocked. So I've almost forgotten how many things, negative things, that antipsychotics are causing. We've got a reduction in cognitive abilities, we've got dysphoria, we've got a reduction in a sense of well-being. There are more studies showing that. This one, for example, looking at patients treated with either haloperidol or olanzapine, and you can see that as we increase receptor occupancy, the score on the subjective well-being score goes down. So the more we block blood dopamine, the worse people feel. And our threshold for effect is 65%, as you remember. Another study showing exactly the same thing. This is risperidone or olanzapine. The more we block dopamine, the worse people feel. One exception to this seems to be dopamine partial agonists, which stimulate as well as block dopamine receptors. They don't seem to be associated in a occupation-dependent fashion with a worsening of subjective well-being. In terms of affect, again, there's a clear relationship between blocking dopamine and positive affect, which goes down, and negative affect, which goes up with increasing levels of dopamine blockade. And alongside that, there is also plenty of evidence of the effect of antipsychotics on cognitive function, which is already reduced in people with schizophrenia. So in making people better, we're making them a lot worse. It does depend on the drug, it does depend on the dose, and it does depend on the extent of blockade of dopamine receptors. But generally speaking, antipsychotics, to put it mildly, are not innocuous. So are we really sure that long-term antipsychotics do more good than harm? We recognize they do harm, we recognize they do good. We've got to strike the right balance. Sorry about the state of this slide. It's very difficult to read. I'll tell you what it says in general. These are case reports of people with no history of any psychiatric conditions or events who take dopamine blocking agents for reasons other than a psychiatric mental health condition. And when those antipsychotics are stopped, they experience a psychotic breakdown. Now, what's thought to be behind this is this process of dopamine supersensitivity psychosis. We block postsynaptic dopamine receptors. In doing so, we provoke the generation of more postsynaptic dopamine receptors, and they may be more sensitive to dopamine than the original receptors. And when we take away the dopamine blockade, we're left with more receptors than we had before we started the dopamine blockade. So this is dopamine supersensitivity. And one of the proofs of this, if you like, is that we can treat a group of normal people with dopamine blockers, stop those blockers, and then see if they become psychotic afterwards. These cases represent neither proof nor disproof, in my opinion. It's clear that this does happen. We can make people psychotic by hypersensitizing their dopaminergic systems, but it doesn't happen very often. This is pretty much all of the cases in the literature, which isn't very many, considering the wide use of drugs such as, for example, prochlorperazine in vertigo. Another aspect of dopamine hypersensitivity or supersensitivity is thought to be the emergence of tardive dyskinesia, which is understood, best understood perhaps, to be a syndrome of dopamine supersensitivity. This graph shows the rise in the prevalence of tardive dyskinesia in the United States between 1966 and 1984. And this is a time where antipsychotics have been established in the treatments of schizophrenia and are being used in more and more people. And you can see the rates of TD in people exposed to antipsychotics are getting higher, to the extent that it's getting on towards half of all patients in psychiatric hospitals in the mid-80s in the United States. And if you look at the rate at which tardive dyskinesia symptoms reduce over time, we can hazard a guess at the time period over which dopamine hypersensitivity declines, and that guess is over a couple of years at least. So this table is arranged in order of the proportion of patients recovering, and you can see the proportion of patients increases, and then almost in tandem, and not exactly, the duration of follow-up increases too. So the longer the follow-up of people with TD, the more likely people are to recover, up to a period of 5 years. So there is plenty of evidence for DSP, which we'll call it for short, psychosis in non-psychotic people, the fact that we need higher doses of antipsychotics in people in their second episode compared with their first episode. In fact, the dose for first episode for antipsychotics is roughly a half or 2/3 of that used in multi-episode schizophrenia. And there is a reduction in response with each relapse, which we'll come to in a minute, and tardive dyskinesia. It would only be fair to give the evidence against, which is that the increase in receptor numbers occurs quite quickly, and yet we see tardive dyskinesia emerging much more slowly. Tardive dyskinesia has only a loose association with treatment-resistant schizophrenia. We'd think if we're developing dopamine supersensitivity, we'd be losing efficacy of antipsychotics, and therefore TD would be linked to treatment-resistant status, to which to some extent it is, but it's not completely a complete association. And relapse is rare in people with confirmed adherence, and it hasn't been until recently that we've been able to have a look at patients who have absolutely, definitely confirmed adherence to antipsychotics. So this is a follow-up of a group of patients at the Maudsley who were put on 3 monthly paliperidone. The ordering, the prescribing, and the administration of those 3 monthly injections is controlled by the pharmacy department, and pharmacists have a particular psychological makeup, which means that they're very rule-bound and very efficient at making things happen. So rather than leaving this kind of thing to community mental health nurses, who are much better at other things, it's left to the pharmacy department, who are very good at making sure things happen on time. And in this group of patients, the average number of injections per year is 4, and there are almost no patients that don't have 4 injections a year. So everybody's fully compliant with medication. You can see that from 18 months, nobody relapses. And a couple of weeks ago, somebody drew the graph out to 3 years. So between 18 months and 36 months, not one person relapsing. These are patients at the Maudsley living in southeast London, which is a highly psychotogenic environment. In fact, this was demonstrated to me a few weeks ago when I ran the London Marathon, the first half of which is in southeast London. Then you cross Tower Bridge and you go into the city. The first half of the marathon was characterized by an overwhelming smell of cannabis. I'm not joking. And by sights of people standing at the roadside smoking enormous, I don't know what they're called, bongs or joints. Once you got over Tower Bridge, that smell disappeared, not to return. There wasn't, I checked around the House of Parliament, there was no odour there. So, highly psychotogenic environment. These people aren't in a controlled trial, they're actual real patients in real life, and they're not relapsing when we give them sustained treatment. So we have this question in our minds, can we stop antipsychotics, particularly in first episode patients? How should we do it? There are lots of studies looking at relapse in first episode patients showing utterly disastrous results. Usually relapse rates of above 90%. In this case, I think this is Robin Emsley. Yeah, 36 months, 97% of patients relapsed. Bob Zipersky, 3-year relapse, 91%, as opposed to those who continued medication, 3%. So the literature seems to say to us, don't even bother trying. It's not worth it for those 3% who don't relapse at 3 years, or 9% in this case. But there are confounders in these studies, not the least of which is the speed at which antipsychotics are discontinued and the manner in which they are discontinued also. Sorry, just before I move on, these are more data from the Maudsley looking at break in treatment, which is, this is the way it was described in the title, a break in treatment and its effects on relapse. All the breaks in treatment were against clinician advice and were what we would call non-adherence to treatment. So it isn't just that people suffer when they relapse. Relapse itself, of course, has an effect on the course of the condition. So if you look at the rate and the extent of, in this case, response in the first episode, 90% of people respond. In the second episode, 63%. If you look at remission rates, 90% of people remit. That's interesting because all responders are remitters in the first episode. 57% of people remit in the second episode. So if we allow people to relapse, then their response to treatment is going to be slower and to a lesser extent. And it's nicely shown on this graph, the rate and extent of improvement on BPRS total and on positive symptom score. You can see slower response and a lower extent of response. But we think that stopping slowly makes a difference. In fact, we know it makes a difference, and we've known for quite a long time. This study, I think, is from the 70s, looking at 100 patients odd, looking at abrupt and gradual withdrawal and the rate of patients remaining stable. You can see the very vivid difference between those two groups of people. It's also dose-related. I don't have a nice slide on this. I've got a photocopy of a paper because this isn't one of those papers that's been digitized. I've ringed the 1968 because that's a typo. It's actually 1969. This shows that the higher the dose that people are on, the more likely they are to relapse. And that's linked to the rate of withdrawal of antipsychotics because we're reducing the dose. So the higher dose you start on, the more likely the patient is to relapse. So this is well-established scientific fact as far as you can go. More recently, Stefan Leucht and others showed that if you look at trials in which lower doses of antipsychotics had been tried to maintain patients relapse-free, you could see a clear dose-response relationship in as much as once you got below about 4 milligrams equivalent of risperidone, you lost the effect on protection against relapse. So slightly difficult graph to read. This is the odds ratio of relapse compared with placebo. So at this point, placebo and active are the same, and that's almost nothing in terms of dose. What was interesting was that if you looked at long-acting injections, they had a different dose-response relationship in as much as the effect of 4 milligram equivalents was rather greater with long-acting injections than it was with oral treatment. And this kind of wasn't particularly discussed in any great detail in the paper, although it's an interesting finding. So I and Mark Horowitz and Alex McCauley wrote in and said, there's something funny about those long-acting injection data. Do you think it's the fact that long-acting injections can't be stopped abruptly, or at least that if you do stop them abruptly, the plasma levels decline slowly. So Stefan Leuk, to his great credit, actually reanalyzed the data, comparing slow withdrawal with abrupt withdrawal, and found that the effect was actually greater. So if you look at the gradual withdrawal people, the gradually withdrawing to 4 milligrams had a much more beneficial effect than rapidly reducing to 4 milligrams. So this is probably the strongest evidence to suggest that one of the ways that we can improve on relapse rates in people stopping antipsychotics, or at least reducing the dose, is to do it as slowly as possible. We also have evidence from these newer, very long-acting injections. So if you look at relapse rates from oral, monthly, and 3-monthly paliperidone, so this is the relapse rate from oral, 1-monthly, and 3-monthly. This is the last day of treatment with oral. It's also the first missed dose of monthly or 3-monthly. You can see the difference in the rate of relapse, but also there's a difference in the extent of relapse. So the proportion of people who ultimately relapse, or at least almost a year, is lower on people who stop 3-monthly than it is on monthly or oral treatment. We don't know whether this graph maintains this kind of differential out to 2 years or 3 years or 10 years. But to some extent, it doesn't matter, or at least it doesn't make it not matter at all, because if you look at how many people have relapsed at almost a year, almost double the number of relapsed having stopped oral than those having stopped 3-monthly. So there's some benefit to be had, even if they catch it with each other. Yeah.
I'm told that we stop at 11:10.
Oh, okay. Where are we now?
Means you can keep talking for 15 minutes and have no questions.
Okay.
Or you could stop in 5 minutes.
I can wrap up in 5, yeah. Thank you. Now, we understand that antipsychotics are effective in relapse prevention. That's because we've done studies, but those studies are polluted by studies where the antipsychotics are abruptly withdrawn. If we want to know whether continuation with antipsychotics is a good thing, we need to make the competition fair by withdrawing antipsychotics from the non-continuation group very slowly so as to maximize or minimize the chances of relapse. That doesn't happen. So this is true of all areas of practice of psychopharmacology. If you look at relapse prevention studies, they pretty much all, or at least majority, reduce the drugs over a very low period, very short period. They rarely mention withdrawal symptoms or describe them. And it's not just the speed, it's also the manner in which antipsychotics are withdrawn. This is a paper by Mark Horowitz, me, and Robin, saying, hold on a minute, the association between drug dose or plasma level and receptor occupancy is hyperbolic. It's governed by the law of mass action. And that means that if you withdraw antipsychotics in a dose linear fashion, 4, 3, 2, 1, 0, the extent to which you reduce activity grows with each reduction, such that the largest reduction is from going from 1 to 0. So if you want to even out that reduction, you go something like 7, 2, 0.8, 0.2, stop. So this question still remains, are we sure that we cannot withdraw antipsychotics? There is a very recent Cochrane review on this, and one of the things it finds is that the risk of relapse is associated with the dose to which the antipsychotic is reduced. As you go below about 10 milligrams equivalent of olanzapine, the difference between continuation and stopping grows, which is something you might expect. But their meta-analysis of risk of hospitalization didn't show any difference between dose reduction and dose maintenance. Where there is a difference is in number of participants having exacerbation of psychosis where that favors dose continuation. But the plain language summary said that dose reduction makes no difference to readmission to hospital, but they're uncertain about the results. May increase the number of participants having a relapse. So Cochrane reviews generally thought of as the pinnacle of data analysis. However, one thing I did notice in this was that their definition of gradual was not my definition of gradual. So gradual is 8 weeks, 12 weeks. And the manner of withdrawal in these studies was not in line with what the graphs I've just shown you. So they were reducing by a percentage, a proportion of the original dose rather than of the previous dose. So even though this is the most comprehensive analysis of discontinuation and dose reduction in the literature, it is polluted, if that's the right word, by studies which did not reduce antipsychotics in the most optimal manner. So are lifetime antipsychotics necessary for all people with schizophrenia? We don't know. Marta says no. I think you're probably right, but I'll stop there. Thank you very much. Happy to try and answer some questions.
So you didn't know the answer at the beginning. You still don't know the answer at the end, but you don't know it at a much more sophisticated level than you did before. So questions and comments, arguments. The lady in the pink, your name, please. Oh, sorry.
David, great talk. You know, I love this talk. I was wondering, given that we started today with showing your prescribing guidelines, should we have reducing guidelines? Because I always wonder when I get to that point, does it matter, yes, the current dose, but also how long the person has been, how many other antipsychotics they've been before the one I'm about to reduce, the age, the gender, and most of the time I bother you because I don't actually know.
Yes, a good question, and gives me the opportunity to advertise my next book, which is the Maudsley Deprescribing Guidelines, which may or may not be called the Maudsley Deprescribing Guidelines. I've got to have discussions with the guardian of the Maudsley trademark. So I don't know what I'm going to call it if it's not the Maudsley Deprescribing Guidelines. But this addresses, in a very practical way, the way which we can go about discontinuing all psychotropic drugs. The title doesn't imply, and I must emphasize this, that we're suggesting to people that antipsychotics, antidepressants, and other psychotropics are not useful, but only that in some cases it's a good idea to attempt discontinuation, and the best way to do it is in this book. And so for each drug we give 3 different regimens where people can taper different psychotropics, a slow, a medium, and a fast. And we also give practical help on how to get some of the doses that are required, which are often much smaller than half a tablet or even quarter of a tablet. So the first part of that series will be out in September.
Professor David.
Thank you very much. Great talk, David. You mentioned how the patients on higher doses have more adverse effects from discontinuation and higher chance of relapse, etc. But of course, based on some of this is based on observational studies. So they're on higher doses because perhaps they're not responding very well, they've got a more severe illness. Whether it's to their benefit to be on high doses may not be the case, but the clinician has kept increasing the dose in the hope that they would respond. So they're not they're not an average patient group.
Yeah, that's a fair nod agreement. Save me talking. Yes, that's absolutely true. That was pretty much the only study that's shown that phenomenon. And as Tony points out, it's in patients who were given those doses in clinical practice and so may well have required them, and those people on higher doses may have had a more severe and relapse-prone illness.
When I started as a consultant, I took over from a doctor who believed in megatherapy. So he thought it was beneficial to be on huge doses of antipsychotics. So he would go up to 4,000 milligrams of chlorpromazine. And so when I took over from him, I thought this is too much. So I would reduce the antipsychotics, but people relapsed at like 3,000. So we had to continue them on, many of them on a very high dose, which would I don't think he pushed the dose up because they were not responding. He just pushed the dose up. It was always said that if the relatives looked a bit anxious, he would give antipsychotics to them as well.
Yeah, so my question was about safety netting and the relationship between the prescriber or clinicians and the patient. So if you do embark on reducing medication regime and person starts to experience emerging symptoms, of course, the one way of stopping them relapsing is that they can then change their mind and go back a few steps or access sort of mental health care more quickly.
Yes, that's a controversial area. In the 70s and 80s, there were studies looking at so-called drug holidays, which showed no benefit for allowing people periods with no treatment. I know it's commonly suggested to people that they withdraw slowly, and if symptoms begin to re-emerge, that they reinstitute treatment. But to my knowledge, there is no evidence that that carries a therapeutic benefit, that it actually works. I'd be happy to be proved wrong or ignorant of the facts, but to my knowledge, that there isn't a study that demonstrates that. One thing I would like to say is to ask people to think about the use of long-acting injections as a means of giving patients the best chance of having a life which doesn't involve antipsychotics. And that sounds counterintuitive. But the most common thing to happen to somebody with first episode psychosis or schizophrenia is for them to be given a normal oral treatment, and for then that patient to stop oral treatment of their own volition without telling anybody, and then for them to relapse, which is pretty much the worst thing that can happen to somebody with first episode psychosis. So in order to prevent that, we can use long-acting injections, because even if they're stopped abruptly, one, we'll know about it because we won't have seen the patient, and two, the plasma levels will decline slowly, so there's not an abrupt cessation. But this too can be sold to the patient. Patients often see it the other way around, which is that they're being compelled to have a treatment that they don't want. But it is their best way of not having that treatment that they don't want, in as much as if we can prevent abrupt discontinuation, then we increase the chances, I think and hope, of people not requiring antipsychotics for the whole of their lives.
Oh, thanks, David. Just a question on supersensitive psychosis and treatment resistance. Do you think the percentages of treatment resistance are related to supersensitivity as a phenomena? And secondly, do you think from a public health perspective, the prescription of antipsychotics in children might increase the baseline rates of schizophrenia long-term, if indeed receptor upregulation is at play?
Two interesting questions. I think Oliver might be best to answer the first one. Dopamine supersensitive psychosis has a variation in time. So in the mid-'80s, it was a thing. It's coming back to be a thing now. And in geography, in as much as it's something that definitely exists in Japan. Everybody in Japan thinks that dopamine supersensitivity psychosis is a thing in Japan, whereas in the UK and the US, there isn't that continuity of belief, and it is, I suspect, a belief. it's interesting that clozapine works in people who have not responded to supramaximum doses of dopamine blockers. And it suggests that clozapine is doing something other than blocking dopamine. One of the possibilities is that it's blocking dopamine receptors to a lower extent, and that might be beneficial. But the main evidence against that is that if you switch people from depots to clozapine, they get better at the same rate as if they were switched from oral to clozapine. So it doesn't seem to matter that you've got something else there blocking all the dopamine receptors. Your second question was about if we give children antipsychotics, will that increase the rate of psychosis in the future? I don't know, but there's a possibility. On one side, you've got the case reports of people becoming psychotic, having had dopamine blockade, and then having it taken away. But on the other hand, you've got the awareness that the number of cases that are reported in the literature is really quite small, probably fewer than 20 case reports.
Eric?
Thank you, David, for the talk.
Eric
So,
Chen.
yes, Eric from Hong Kong. The idea of a minimal effective dose must be somewhat individualized.
Yes.
I wonder what you think about personalized medicine. Could that help in guiding us towards estimating that dosage for the individual patient?
Yes, you're absolutely right. And I think we need to go back a bit further and to reiterate how it is that antipsychotics work. It seems to be that for each individual, there's a dopamine occupancy threshold above which you get all of the effect and below which you get no effect. And that there will be an average occupancy threshold for a population, but there'll be an individual one for an individual person. And you're quite right. We could do some work in identifying each person's individual threshold. I suppose one other thing to say about that is that people's threshold tends to move a little bit according to the rate and nature of the discontinuation schedule. So, for example, you might say, well, patient A, they relapse when you get below 2 milligrams. But actually, if you were to reduce the dose slower and in a linear fashion in regard to dopamine occupancy, you might find that it's 1.5 or even 1 milligram. So even within an individual, it might be different. But I take your point, and I think you're exactly right, that individuals will have a dose usually at which they begin to increase their risk of relapse.
So I've been overruled. So the last question is from Jonas.
Last question then. Would you, a great talk, by the way.
Thank you.
Really practical and hands-on. Would you favor, given that you think the slow reduction is a good thing, would you favor the drugs with a very long half-life, even for the orals, or would it be kind of not matter that much?
I think it does matter, but we don't have a great disparity in half-life in orally acting drugs. So the longest acting drug I think we have is probably penfluridol. It might be cariprazine.
Cariprazine.
Yeah, their half-lives, including their metabolites, are in the weeks, 2-3 weeks. So it's possible that reduction of those allows for a better linearity of pharmacological effect reduction. There's an interesting study looking at the timing of relapse after having stopped cariprazine compared with other drugs, and it is as you expect, all shifted on 3 or 4 weeks compared with a short-acting drug like quetiapine. But there was, to my awareness, no difference in the extent of relapse. It just does change the timing. But we're talking about abrupt discontinuation of both short and long-acting drugs. I think if you had a tapered discontinuation of long-acting drugs, you may find a small advantage.
So thank you very much, David.
Thank you.